So thanks everyone for joining us for our Q&A session today. Dr. Mells is back with us today. Thank you so much for joining us. I know it's a really busy time for you as well. You take time out of your clinic to come and join us. We really do appreciate it. And we're also taking some of your time next weekend as well. You're joining us for the patient conference as well, which is not this weekend, but the next weekend in Edinburgh. We're really looking forward to that. We are absolutely fully booked now in terms of people coming in person to join us at the event, but virtual attendance is still available. So if anybody wants to join us virtually or is in another country, and because of the time difference, if you want to register for virtual attendance, you'll be able to watch it on catch up through that as well. So please pop a little registration in and I'll set you up for virtual, which is great. A little bit of housekeeping just before we start, just to remember that these Q&As don't take the place of a consultation with your own clinician. In these sessions, we're aiming to provide general medical information and not medical advice. So often we'll generalise your question to support that and the answer as well. I'll be recording the session here in Click Meeting. And just to remember as well that on the right-hand side of the screen, people in the room that are on the right-hand side of the screen with us, where you can see the comments and the questions coming in there, they're not visible on the recording that we put up on YouTube, so that we can keep this a bit of a safe space. And any questions that come in that way, I'll give to the doctor verbally. So if you have any questions for us, please pop them in the chat and we'll make a start with the questions that we've had sent in so far. So our first question today is around a patient who's been recently diagnosed and has been on URSO since the beginning of July. The last few weeks, they've been having horrible body pain to the point they can't function, nausea, weakness, etc. Specialist has taken them off URSO now, currently not on anything and waiting to be reassessed in a couple of weeks. Is this a normal response to URSO?
No, no. URSO is actually, just generalizing, exactly as you said, Mo, URSO is normally extremely well tolerated, actually. The usual side effects that people might get when people first start taking ursodeoxycholic acid would be a slightly gripey tummy, sort of crampy tummy pains, that sort of thing, maybe some loose bowel motions, maybe some nausea, and that doesn't happen in everyone. I very often recommend that people start at a lower dose and build it up gradually to the maintenance dose over the course of a month or two, just to allow the bowels to get used to the ursodeoxycholic acid. That seems to work pretty well. But as a general comment, URSO is a very, very well tolerated medication by the vast majority of people. So all of those symptoms that the questioner experienced are quite unusual. That doesn't mean they aren't side effects, though, because people have very individual responses to medication. So they could easily be side effects. And very often the way that we try and tease it out is to work out when it is that these symptoms began in relation to starting the medication and what happened to those symptoms when the medication was discontinued. If the symptoms arose very soon after starting the medication and the symptoms disappeared very soon after stopping the medication, then it looks like a side effect, and it might mean that that medication will not be tolerated by that individual patient. But they are very unusual symptoms side effects that have been described. So most people can trust, if they're about to start URSO, most people can trust that they'll get on quite well with it.
That's great. Our next question is around a medication called, and correct me if I'm wrong, allopurinol tablets for gout. And the patient has been told that these can affect the liver. The person who got in touch, their mother had PBC later in life, and it concerns them that they might develop it too, and they were just worrying because of the liver effects.
Yeah. Allopurinol can affect the liver. I mean, in most cases, it will just be a mild elevation of the liver blood tests, which often settle during treatment or will settle soon after the treatment is finished. Very occasionally, very rarely actually, I should say, very rarely, allopurinol can cause a more significant liver injury. But I couldn't find any evidence when I saw that question. I couldn't find any evidence actually that allopurinol leads to PBC. Now, of course, people with a family history of PBC are quite rare, so it'll be very difficult to find evidence on people who take allopurinol and have a family history of PBC. That would be a very unusual situation to be able to report on. But I don't think that it's likely that allopurinol increases the risk of developing PBC, even when there is a family history. So I think if this person needs the allopurinol because gout has been troublesome, they're probably better off taking the allopurinol to prevent the gout than not taking allopurinol on the off chance that it could potentially, without any evidence, lead to PBC, if you see what I mean. Unfortunately, it's always a balance of risks with medication. There is, no medication comes harm-free. So it's always about balancing the potential benefits and the potential risks. But I think in this particular instance, the potential risk of PBC is so low that the person is probably better off taking the allopurinol, perhaps with some monitoring of the liver tests.
Great, thank you.
If there are worries, though, I mean, it is obviously a very individual situation. So I think, probably the real advice here actually is to have another chat with the clinician who prescribes the allopurinol and just make sure that all of these concerns have been voiced and that the appropriate reassurance has been received.
Mm-hmm. Yeah, no, that's a good point. I didn't say that if they had discussed that with their doctor, to say that they were concerned about that in particular. Thank you. Our next question is around normalising LFTs and a younger patient, potentially PBC being more aggressive in a younger patient. So I'll read the question. I won't read it all because I did put some information just in there for you, Dr. Mells, but it's a 35-year-old female diagnosed last year post birth of their first child. On our SO since November 2024, an ALP remains outside of the normal range. It was very high postpartum, but naturally decreased over time to 144 before starting our SO, but it's yet to normalise, and on latest blood tests, it was 168. FibroScan a year ago was 3.66. The patient's asking is, should they consider exploring second-line therapy, as the advice in our Q&A seems to be to normalise LFTs where possible, but their consultant doesn't think that's necessary at this point. And also just being aware that PBC can be aggressive in younger patients and keen to prevent as much damage to liver as possible from the outset.
Firstly, I think the person can be reassured that actually they are not at great risk of disease progression from PBC based on the information that has been provided so far. So, whilst it is true to say that in younger individuals, we would prefer all of the blood tests to be normal, because in a sense, that guarantees that that patient will be at the lowest possible risk of disease progression. It's also true to say that a person with an alkaline phosphatase of 163 has very, very little inflammation inside the liver, and therefore is unlikely to come to any harm for many years to come, especially if the FibroScan was done a year ago and had an excellent result of less than 4 kilopascals. That FibroScan score indicates that there is basically no existing scarring as a result of the PBC, and the alkaline phosphatase of 163 suggests that while there might be some ongoing disease activity, it is so low grade that the rate of disease progression will be so slow that the person is unlikely to develop significant scarring for many, many, many years to come. Often, the reason that we want the liver test to be normal in younger people is not because the disease is particularly aggressive, but because a young person has decades and decades in which to accrue fibrosis. So I really don't think this person needs to be worried that they have an aggressive process happening at the moment. The blood test suggests that is not the case. It is true that PBC is more aggressive in people who are younger. That is correct. But it would be reflected by the blood tests. So if this individual had aggressive PBC, their alkaline phosphatase would be very high. That would be the evidence that it was aggressive. It's not simply being young that makes it aggressive, if you see what I mean. I think this concern is probably, to some extent, it is probably our fault, the community's fault. perhaps even a little bit the PBC Foundation's fault, in that we have tried very hard to communicate this message of normal is better. Of course, normal is better, but that doesn't mean that people who have near normal blood tests are at great risk. Normal means no risk, if you like. Near normal means very, very low risk. And of course, it would be great if everyone was at no risk, but there are implications to that approach. There are certainly cost implications for the health service as a whole, and the actual health economics of treating people with very low risk disease versus no risk disease, and so on, have not been calculated. And there are costs to the individual as well, because as we discussed a moment ago, no drug is harm-free. Medications like obeticholic acid have side effects, like elafibranor, like seladelpar, bezafibrate, they all have side effects. Some of those are potentially long-term side effects that we don't know about yet, because these drugs haven't been used for 20, 30, 40 years. So you're potentially trading one set of problems for another. I think this patient has probably received reasonable advice, actually. FibroScan reassuring, alkaline phosphatase pretty good. They probably don't need second-line treatment, but the thresholds at which we give second-line treatment are constantly being revised on the basis of evidence that is emerging over the course of time. And it might well be that actually in a year's time or in 2 years' time that we're actually suggesting something slightly different, that younger people, because they have many, many, many years in which to accrue scarring, that those people should have second-line treatment to achieve normal liver tests. But that isn't the current recommendation, and it is because the risk is still low. Does that all make sense?
Yeah. And I would also say to this patient, your diagnosis is actually very similar to my own. I was 36 when I was diagnosed, following the birth of my daughter as well. So if you want to have a chat, or just from a lived experience perspective, please just reach out and we can do that. We can have a chat as well. But very similar. And just to know, I'm now 54, so that was 18 years. So if you want a little chat, just reach out and we'll arrange that as well. So thank you for that.
No, the other thing to say, actually, by the way, is sorry to sort of go round and round on this, but it's a difficult issue for a lot of people. A decision now isn't a decision forever. So, it isn't a case that we make a decision about second-line treatment and then we discharge the patient and say, well, come back in 30 years and we'll see whether we got it right or not. Yeah. In fact, what will happen is that this patient will be seen again in say 6 months or 12 months. They'll have another fibro scan in 1, 2, or 3 years. They'll have ultrasound scans and so on. And if it looks as though there is disease progression, so if the FibroScan score changes, for example, even though the alkaline phosphatase has remained around 160, then second-line treatment could be entertained at that point. And you would still be giving the second-line treatment long before the person had developed cirrhosis. So I think that this individual, whilst it is worrying, it is of course frightening to have a long-term condition. I think they can be reassured that actually things are looking pretty good at this point in time. But they must be monitored into the future.
Yeah, no, that's great. Thank you for that. Next question. If you've been on OCA for 3 months and all liver enzymes have normalised, is it necessary to increase the dosage from 5 to 10 milligrams daily? Also, if indeed your dosage is increased and you've had no side effects with 5 milligrams, will doubling the dose possibly cause side effects?
Well, again, a very good question. Because this is a situation that does arise. We won't be able to provide an answer for the individual because we probably don't have quite enough information to say. But I think in general, if the liver tests have normalized and they're now well within the normal range, so not just below the normal range, but well within the normal range, and if a FibroScan, for example, had been done earlier and that showed no significant fibrosis, then it would probably be reasonable to continue with the current lower dose. the lowest effective dose is often how we approach medications. On the other hand, if the alkaline phosphatase was only just below the upper reference, or there was a FibroScan which suggested that there was actually significant fibrosis already, and you were really, really keen to prevent there from being any progression of fibrosis, then it might be better to go up to the recommended dose, which is 10 milligram per day, so that you can really optimize the treatment and minimize any chances of disease progression. So it's very contextual. It depends on all of that information to make that decision. But I suppose the general response is that there are circumstances when the lowest effective dose is reasonable to continue. In terms of side effects, unfortunately, it is true that some people get on absolutely fine with 5 milligram daily of obeticholic acid, but when you bump up the dose to 10 milligram a day, side effects emerge. But that doesn't mean you shouldn't do it. I mean, a perfectly reasonable approach with medications is to increase the dose and see how you get on. If there are no side effects, fantastic, continue with that dose. If there are side effects, you can always go down to the lower dose, which, by the way, was effective.
Great, thank you. We've got a patient who's had PBC for over 22 years, and only since Christmas this year they've needed varices band-aid. Will this continue fully now that this has started to happen? And just questioning why it would start now after all these years, and if there's anything preventative they can do to help with it.
So again, we won't be able to provide individual advice here because unfortunately, once again, we don't have quite enough information to be able to say what will happen in the future for this individual person. But I think the general observations are that 20 years is quite a long time for any disease. It is possible that over the course of 20 years, even if the PBC had been reasonably well controlled and without too many side effects, symptoms rather, that there has been some slow and steady disease progression in the background, which potentially wasn't obvious from bloods, from the intermittent scans and so on and so forth. And this person has now reached the point of potentially having cirrhosis with portal hypertension and varices. It is also possible, however, that this person does not have cirrhosis and could be one of the 10 to 20% of patients with PBC who develop something known as non-cirrhotic portal hypertension, which is where there is portal hypertension and varices, these dilated veins in the gullet, even though the liver is not actually scarred. That can happen, and it is one of the reasons that people with PBC should have occasional ultrasound scans every few years, even if the FibroScans show that they do not have cirrhosis. So I don't know which applies to this particular individual, but it could be either of those possibilities. Once varices have developed, though, irrespective of the context, they don't go away without treatment. It sounds like this person is having the correct treatment, though. They're having endoscopic variceal ligation to get rid of those varices. What usually happens is that the banding is repeated every 2 to 4 weeks until the varices are gone, then repeated a few months later to make sure that they're still gone. And then the endoscopy is repeated every 1 or 2 years to make sure that those varices haven't come back again and don't need any further treatment. So I guess that will probably be what happens to this particular patient. But, you know, the simplest thing to do would be for them to ask the clinician who's in charge what the plan is in terms of further endoscopies and further banding. They will probably also be advised to take a medication called carvedilol, which is a beta blocker that reduces the blood pressure inside the portal vein and helps to reduce the risk of bleeding from these dilated veins.
Great, thank you. I really like this next question because it just shows how well educated our patients are. There isn't a great deal of information out there on the use of triple therapies. With the two new drugs, elafibranor and seladelpar, out there and now in use, would, for example, a combination of urso, elafibranor and OCA be potentially run as third-line treatments in the UK, or is it already being used? Is there any data or any findings on triple combination therapies? And are there any cohorts of patients currently on triple therapy in the UK?
There are certainly patients on triple therapy already, although the triple therapy that most patients are on is a combination of ursodeoxycholic acid, obeticholic acid, and a fibrate, either bezafibrate or fenofibrate. And that's simply because the fibrates have been around for a lot longer. I mean, elafibranor is licensed and it is available on the NHS now, but it's only relatively recent that it has been available. So there hasn't been much opportunity to get people onto triple therapy consisting of urso, OCA, and elafibranor. But it will undoubtedly happen. We don't yet have much information on how effective that particular combination is, but we would predict that that it will be effective because people who go on to triple therapy containing a fibrate have improvement in their liver tests. So we would expect the same to occur with elafibranor. And there will be people, UK PBC included, attempting to gather data on this to demonstrate that there is that improvement in first the biochemistry and then the long-term outcomes in those who go on to that combination. And of course, it is also important to collect information on the side effects associated with that particular combination. People taking a combination of urso, obeticholic acid, and bezafibrate seem to do pretty well with it in terms of side effects. We would hope the same is true for elafibranor and seladelpar in due course, but nothing can be guaranteed. So it will be important to collect that information as well.
Mm-hmm. Great, thank you. I'm going to take the next question, and also there's a question in the chat which relates to GGT as well. So the question is it possible to be symptomatic with debilitating fatigue and some itching with normal LFTs but GGT elevated and strongly positive for AMA? And then the question around ALP and GGT in the chat is, if your ALP returns to normal, will your GGT return to normal? Theirs seems to rise and fall in sync with the ALP.
Okay, so the first bit is about people who, the diagnosis of PBC essentially. So the diagnosis of PBC really depends on 2 out of 3 things. It needs to be a combination of either elevated alkaline phosphatase and positive antimitochondrial antibodies, or a combination of elevated alkaline phosphatase and a liver biopsy showing PBC, or a combination of antimitochondrial antibody positivity and a liver biopsy showing PBC. So any of those combinations will get you to a diagnosis of PBC. Usually, however, if people have antimitochondrial antibodies but normal alkaline phosphatase, we will generally advise against a liver biopsy. Because even if they've got early PBC, it is so mild that they're not going to come to any harm from hanging on a little bit. We'll generally advise keep an eye on the blood tests, and we'll consider treatment if the alkaline phosphatase becomes abnormal. It could be that this person who has symptoms that are consistent with PBC, positive antimitochondrial antibodies, elevated gamma GT, but normal alkaline phosphatase, that they fall into that sort of category of someone who does actually have PBC, but it's very early. It hasn't pushed up the alkaline phosphatase yet, and therefore it's mild enough not to really need treatment with ursodeoxycholic acid at this point in time. But I suppose that the person who's asking the question is probably more keen on having some sort of clarity around the diagnosis. They're probably asking, do they have PBC or not? Very difficult to say. The only way you could know for sure would in fact be to do a liver biopsy. And I guess the person who's asked the question will probably need to have a chat with their own clinician about whether that's really warranted. It might be, that a biopsy is worthwhile doing so that you can be absolutely confident about the diagnosis, so that you can then be confident about using medications such as cholestyramine or rifampicin or naltrexone for the itching.
Yeah.
So that would be potentially a reason to proceed with a biopsy. You probably wouldn't want to be offering treatments such as rifampicin to somebody who didn't have proven PBC, because it's an unlicensed medication and it comes with a whole bunch of side effects.
Mm-hmm.
So if the biopsy is going to allow you to offer certain treatments, then perhaps that biopsy is worth it. On the other hand, it might be that actually once you've weighed up the pros and cons of biopsy, you find that actually you'd rather not have one. And therefore you're back to that situation of, well, I'm not sure whether it is PBC. Let's hang on a little bit and see what happens to the alkaline phosphatase. But I think the person who asked the question will have to have that quite detailed conversation with their own clinician, just weighing up the advantages and disadvantages of a biopsy to obtain diagnostic clarity.
Mm-hmm. And just to say, if that person needs a bit of support with that, please just reach back out to us and we can help with that. That was something that had gone through my mind, was thinking if there's symptoms there, particularly the itching, if there's no diagnosis, what would happen about them then potentially asking for treatment for those symptoms? So that's what you've covered. That's kind of where I had gone with it as well, thinking what happens there if they don't have a diagnosis.
Yeah, and it could also work the other way around, of course, that that actually by doing a biopsy you show that there is no evidence of PBC whatsoever, and then it becomes a question of, well, what else could be causing the itching? So it might be helpful, but I think it's a very, very unique situation, unique to that individual, and the detailed discussion I think needs to happen between the patient and his or her clinician. As for alkaline phosphatase and its relationship to the gamma GT, they do tend to go up and down together. You might therefore say, well, if they go up and down together, and the reason the gamma GT goes up is also because of the damage that happens to the liver in PBC, why don't we make a diagnosis of PBC on the basis of the gamma GT? And the answer is that actually there are just too many other things which affect the gamma GT. So the gamma GT can be elevated because of medications that people are taking. It can be elevated because they drink a little bit too much alcohol. It can be elevated in obesity. It can be elevated in cardiovascular disease, coronary artery disease, and so on. So there are so many other factors that can influence the gamma GT that it wouldn't be a particularly useful measurement for making a diagnosis of PBC. But it does certainly go up and down in correlation with the alkaline phosphatase.
Great, thank you. Next question's around magnesium. We've got a patient who's struggling to sleep as a result of steroids. They have PBC and AIH and have read that magnesium supplements can help with sleep, but not sure if my conditions will allow to take them. Would appreciate a steer on this.
Yeah. Again, this will really depend on the situation. I mean, in reality, the reason for the insomnia is probably the steroids, actually. So in a sense, it's not really a question of going on to magnesium. It's more a question of how do you get off the steroids. Unfortunately, with treating autoimmune hepatitis, it often is quite a slow and steady reduction in the steroids. It can take months to years to finally get off them. But that's the thing that needs to change to help with the sleeping. Magnesium supplements are probably going to be okay, but again, we don't really know the state of this person's liver, their other medications, what the magnesium levels are, what their kidney function is like, what the bone profile is like, and so on and so forth. So in reality, I'm afraid the question probably needs to go back to the person's own clinician, firstly for a discussion around the steroids, and secondly for a discussion around the safety of the magnesium supplements. In general, magnesium supplements are probably safe in liver disease, but as a very general comment.
Yeah. Our next question is actually about vitamins in general as well. I'd like to know which vitamins are recommended for people with PBC. I'm aware there are some we should avoid, but we'd like to know what ones would benefit me. So again, just from a very general perspective, thinking about vitamins.
Well, I think this will depend on which clinician you ask, actually. I mean, I personally don't believe in supplementation. If you don't need it, we should be getting our vitamins and all of our nutrients, vitamins, micronutrients, macronutrients, and so on. They should all be coming from the diet that we eat. And if people are eating a healthy, balanced diet, then that will be providing everything that they need. There are some circumstances where supplementation is very necessary. So, for example, if patients have got significant ductopenia, meaning lots and lots of damage to the bile ducts inside the liver, and they have persistent jaundice as a result, then they might be malabsorbing, not getting quite enough of fat-soluble vitamins like vitamin A, vitamin E, vitamin D, vitamin K. And under those circumstances, that individual might need supplementation of those vitamins. But it's a rare situation to be in, and it would generally be done based on having shown that those vitamins are low. Likewise, people with a very advanced liver disease sometimes lose their appetite. They don't eat enough to keep up with the needs of the body, and under those circumstances, they might need general supplementation, a micronutrient and multivitamin combination in order to maintain levels of those nutrients. But for most people, the vast majority of people with PBC, including people with cirrhosis from PBC, all of this should be coming from a healthy, balanced diet.
Great, thank you. I'm going to move on to what is the last question on the list we've had sent in. So just to say, I see that there are a couple of questions in the chat here. I'll come to them after this one. And if there's any other questions for Dr. Mells, please pop them in there and we'll get to them just shortly. So this patient was recently diagnosed with PBC. Recently diagnosed with PBC and taken urso with good initial results. They were diagnosed in April. Total cholesterols and LDL-C values are high, although declining since starting urso, and the GP has asked them to come in and discuss statins. All the reading they've done around this suggests that a high LDL-C result is in fact caused by lipoprotein X, which is not associated with increased risk of heart disease. What is the current thinking about statins and PBC?
Again, this is it's an important question, and it does crop up from time to time. It is true to say that in PBC with significant cholestasis, that the cholesterol can be high because of lipoprotein X, and lipoprotein X is not atherogenic, meaning that it doesn't increase the risk of cardiovascular disease or cerebrovascular disease. So people who genuinely have elevated cholesterol, total cholesterol, and elevated low-density lipoprotein cholesterol because of lipoprotein X don't actually need statins. What they need is better control of their PBC. However, the vast majority of people with PBC, unfortunately, exist in the real world and are as prone to the mixed hyperlipidemia as everybody else, the type of hyperlipidemia that does benefit from treatment with statins. So most people with PBC actually are going to benefit from statins. And I think it's reasonable to take the GP's advice on that. I suppose the way to work it out from the patient's and the physician's perspective is how significant is the cholestasis? So how well or badly controlled is the PBC? If the alkaline phosphatase is very high and the bilirubin is potentially slightly elevated as well, then it could well be that the cholesterol is elevated because of the PBC. And there are two options there. One is to see what happens on treatment with the ursodeoxycholic acid. If everything just steadily improves as the liver disease is controlled, then probably no need for the statins, hang on. The other option would be actually to measure something called apolipoprotein B, which gives you a clue as to whether the cholesterol is raised because of lipoprotein X or whether it's raised because of the standard mixed hyperlipidemia that most of us have, unfortunately, as we get a bit older. That will probably be beyond the GP, though, and the GP would probably need to seek advice from the local lipid specialist in order to know exactly which test to ask for and how to interpret the results. On the other hand, if the PBC isn't that badly controlled, if the alkaline phosphatase is only a little bit high and the bilirubin is well within the normal range, then it is slightly less likely that the cholesterol is elevated because of lipoprotein X. And it's probably better to just follow the advice of the GP in terms of calculating the future risk of heart attacks and strokes and deciding whether a statin is needed on the basis of that.
That's great. Thank you. I'm going to just take one quick question on the GGT and then we'll move on to the longer question. So does the sleeping aid zopiclone have effect on GGT? You mentioned that earlier that there were some things that could affect it. Can that affect it?
I'm not aware of zopiclone affecting the gamma GT, actually. I don't think it does, but I mean, invariably when we're trying to answer these sorts of questions, what we tend to do is to go and do some sort of literature search to see if there's any known association between the two. But it's not something I'm aware of it as being a culprit.
Great, thank you. So the question that I'm taking out of the chat here is, received a letter last week that told me I have PBC and I've yet to be able to speak to the doctor. There is lots of very useful information on your website. What would you recommend that I focus on to help myself until my clinic appointment at the end of September? They were prescribed or so in January. First of all, welcome in. I'm really pleased that you found us so quickly after your diagnosis, and also that you're here and you're able to ask a question of Dr. Mells as well, which is great. So newly diagnosed, what would we recommend they focus on until their clinic appointment at the end of September?
I'm not sure that there's really, I mean, the end of September is pretty close now, so there's probably not a lot to be done before the clinic consultation. Perhaps the only thing to do is to potentially focus a little bit on mental health. People often feel very frightened when they first receive a diagnosis of a long-term condition, but invariably it's not as frightening as it first appears. So just having a little bit of a think about that might be quite useful. And then the other element actually is potentially to prepare for the next appointment, because I guess there you go.
As if by magic, yeah.
Prepare for the next appointment, because that's probably going to be the opportunity to catch up in terms of what does the diagnosis mean for the individual, what additional tests are needed at this point in time, how should we interpret the tests that have already been done, and so on and so forth. And I think Mo, you've probably got, is that the
yeah, so that's the appointment prep guide, and that's the one that sits along it, which is discussing PBC with your clinician. So exactly what you were saying there, one to have an idea about the types of tests and things that you'll get checked, and then this one's to prepare for your appointment.
Yeah, and take it along, because I think there's space to write in this, isn't there?
Yeah. So this one opens up and it lets you just prepare your questions and write down some notes and stuff. So, and that's available on our website, or if you want a paper copy, get in touch and we'll pop one out. I would also say, if you haven't already, give us a buzz on the helpline. I think when you're newly diagnosed, it is quite good just to have a chat as well. The mental health bit that you picked up on there as well is really important. We hold quite a lot of online sessions. We've got a weekly session for wellbeing, as well as our Q&A sessions that we do on a Thursday, and just other opportunities to meet other patients as well. But I would say, yeah, we're getting really good feedback on our appointment prep guide in terms of people taking time to fill it in. I think especially if it's your first appointment, thinking about all the things that you might want to ask, it can get a bit overwhelming and you might forget. So that wee bit of prep ahead of time is really useful. I would say reach out to us as well for a wee chat if you haven't done already. I'm hoping that you maybe have, because you're here and you're joining us, so you know about our services. But if there's anything that we can help with, please just reach out to us as well. And then we have another question around, I've been told I have compensated advanced chronic liver disease. FibroScan was 17.7 kPa and 302 cap, so likely to have cirrhosis and fatty liver. Will fatty liver make the cirrhosis progress quicker? No hypertension, no portal hypertension, ALP 158, all other bloods normal. They've had PBC since 2014.
Well, yeah. I mean, strictly speaking, we don't know without a liver biopsy, actually. So in a sense, to be absolutely 100% certain of this, you would need a liver biopsy. And if that biopsy showed steatohepatitis, meaning inflammation as a result of the fatty liver, then we would know that that the fatty liver is contributing to the disease progression, and it would then be worthwhile making efforts to overcome the fatty liver. I don't know that anyone would really want to do a liver biopsy in order to obtain that absolute proof, though, because in general, people will benefit. The treatment of fatty liver obviously is to lose some weight and to treat associated conditions such as diabetes very well, treat hypotension very well, make sure that the lipids in the bloodstream are controlled, and so on. And by and large, people would benefit from that anyway. Even if they didn't have a biopsy proving steatohepatitis, people would probably benefit from some weight loss or overweight, good control of diabetes, good control of blood pressure, good control of cholesterol. So I think this person, on the basis of the information that they have provided, should probably think about healthy living in order to get their weight under control and treat any associated metabolic risk factors. And that might help their general health, and it might also help to slow down disease progression. But as I say, to be 100% certain, you would need to do a liver biopsy.
Great, thank you. Just when we were touching on there's a question about diet. Which diet is better for people with PBC, Mediterranean, or the AIP autoimmune protocol paleo diet?
We don't know is the answer. It would be wonderful to know actually what sort of diet and other lifestyle interventions would benefit people with PBC and other autoimmune conditions, but it's incredibly difficult to do a study of diet. Firstly, you would need lots and lots and lots of people with PBC. They would need to be willing to commit to a particular diet, which no one ever is. So it's really very, very important, very, very difficult to gather that sort of evidence. So, I don't know. I think that said, my instinctive response to this is that the Mediterranean diet has quite a lot of evidence in terms of its benefits for cardiovascular disease, cerebrovascular disease, blood pressure, and so on. Whereas the paleo diet, I don't want to be too dismissive of anything because I'm not an expert in this, and a dietitian would probably be the person to answer. But the paleo diet, which I think is a very meat-focused diet, I always think when I see it looks just a tiny bit faddish. And I personally would have some reservations about people adopting it without a lot more evidence that it is truly effective. I think if anyone is really considering going on to a paleo diet, then they probably ought to speak to an expert, not us on the webinar, because we're not experts in this, but actually speak with a dietitian who really knows their stuff to work out whether they're likely to benefit from it or whether it actually will just lead to a whole different set of problems.
Great, thank you. That's all the questions we've had sent in and all the questions that are in the chat. So while I give the people with us a chance to ask any more questions, I'm going to do a plug for our patient conference. So I'm going to switch over and bring up the draft of the patient conference agenda, and I'll just chat a wee bit about the conference while I give the people in the room a chance to ask any more questions before I release Dr. Mells back to his patients a wee bit early, just in case there's anything else. So we've just been working on finalising the agenda for the patient conference, and the very latest information is all up on the website. As I mentioned earlier, in-person attendance is full as it stands at the moment. If we do get any cancellations, we'll advertise them on our socials, but they're full for just now. But we do have lots of space if anyone wants to join us virtually. And if you register to join us virtually, it means you can watch it on catch up as well. We will get everything up that we record onto we can't record all the sessions, we just record the sessions that are in the main rooms. But once we've got the sessions all recorded, we will put them up onto YouTube, but that usually takes us a few weeks following the conference to get that done. So we do have Dr. Mells is joining us on Saturday. Professor Jones is joining us on Saturday as well. We also have a nurse specialist, Sandra Walsh, joining us. We have a pharmacist specialist, Alison Boyle, joining us. and we have Dr. Nasir Hussain and Dr. Jess Layton joining us as well. So our panel of doctors will be large this time. We'll have lots of people joining us, which is great. It does feel quite clinic focused this year, but I think with the changes we're having in PBC with the new medications, I think that's really useful for patients to hear that as well. We also have lots of breakout sessions going on. So for those, we have things like advocating for yourself at clinic appointments, health and wellbeing that we've touched on there. Cheryl will be doing an introduction to Choose Me Tuesday that she does every week. Robert's doing some tools and techniques to help handle anxiety. We've got Rebecca, our nurse that's with us at the foundation now. She's doing a session on complementary and alternative therapies and medication. I'm doing a session where you can meet patients who've had transplant, and also a session on workplace rights and reasonable adjustments and access to work and that type of thing. So it's a full packed agenda, and we're really looking forward to it. As it's our favourite time of the year when we start to look at bringing all our patients together in the one room, and we're really looking forward to it. We're also doing, Robert and Sandra Walsh, our nurse specialists, they'll be leading a session on mental health and PBC. Mental health and PBC was one of the biggest things that came out of the summit this year in terms of where the community would like to put its attention. So we've put in a specific session on that this year as well, so that we can focus on that. So please, if you've not registered and you'd like to join us virtually, you'll find the details on the website. Please do so. We'd love you to join us. And I'm just going to, I think there's just a little question came in there. With bone pain in the legs, can this be PBC? When I was a child, it was called growing pains.
Bone pain, pain in the long bones is actually quite common in people with PBC, so that's definitely a well-known symptom. It might be worthwhile just making sure that vitamin D levels are where they should be, because that can sometimes be low in people who are getting non-specific sorts of aches and pains, and checking the bone profile, actually, the calcium levels and so on at the next appointment. But as a general comment, yes, bone pain is not unusual in people with PBC.
Great, thank you. Last shout for questions for people in the room, and then I will give Dr. Mells some time back and let him go back to his patients. Thank you so much for taking the time to be with us, and I look forward to seeing you next week as well, Dr. Mells.
Okay, bye for now. Thank you.
Take care. Thank you, guys. Bye.